school where a young lady was abused, and the family did not believe her. And the mom even blamed her for the clothes that she was wearing, this teen, that she was wearing provocative clothes, and she brought that on herself. Very sad situation. However, that leads to a higher level of stigmatization. Also, the child's prior knowledge and beliefs about sex and about what's right and what's wrong regarding sexual behaviors, as well as where they are developmentally in those stages as far as their knowledge and how far they've progressed, can play a role. All right, some symptoms that you're probably going to encounter with your clients who have been sexually abused: heightened sexual activity or permissive attitudes. And this may be young children who are abused may kind of progress through those stages really quickly, leading to, more sexual activity as a teen. This could be from some of those things we talked about in the past, like that they believe maybe that's the only way that they can attain affection, or that means that my boyfriend loves me because, he wants to have sex with me. Prostitution, and obviously early pregnancy kind of goes in the same line of those more early sexual behaviors. More sexual risk-taking behaviors. They may be more open to various behaviors sexually that other children would not be open to. Younger voluntary intercourse, or kind of the opposite, like sexual avoidance or some sort of dysfunction sexually, that they don't want to have anything to do with it because it reminds them of those abusive events, or triggers some uncomfortable anxiety, something of that nature. Or compulsive sexual behaviors, which again may manifest themselves as masturbation or pornography, or even becoming perpetrators themselves. Okay, and that was from that particular that research, Knoll et al. And then Beach and his colleagues, they found evidence for antisocial personality traits following sexual abuse, as well as depression and substance abuse. And then Dworkin and his colleagues found symptoms that coping mechanisms in the form of some sort of cognitive discontrol, like impulsive and compulsive tendencies, again, under sort of the anxiety realm, such as compulsive masturbation or pornography, or obsessive compulsive behaviors, eating disorders even, and other anxiety disorders. And like I said, some OCD kind of stuff with impulse control issues. All right, and I want to mention the conservation of resources theory. This is where an individual, as they develop, you gain more self-esteem and more self-confidence in yourself and more self-efficacy as you develop appropriately. So for those individuals who have a derailed development because of sexual abuse, their self-esteem may drop, and their own self-efficacy is often lower. Maybe due to some of that other stuff we talked about with the lack of power over the situation, could lead to a lack of self-efficacy. Childhood abuse can lead to a reduction in resiliency resources, which the resiliency resources are self-esteem, self-efficacy, which can lead to psychological distress, which in turn has a negative impact on their ability to function. So individuals with low self-efficacy are less likely to be assertive in relationships, less likely to protect themselves in risky sexual situations, and individuals may perceive that they have very little control over their self and their environment, because that was kind of ingrained in them early on, that they don't have any control, that somebody else is going to invade their body and their space, and they don't have any power. And again, so the greatest psychological distress, they may feel unworthy of having any positive relationships, maybe because they're damaged. That would be a cognitive distortion there, may not know how to behave in relationships in healthy ways because they've never really experienced that, or may over-sexualize romantic relationships, sort of hypersexual behaviors. Okay, so what do we do with all that? Knowing all that, and then we have clients come to us and they're presenting with these various symptoms. So back to the traumatic sexualization theory, Finkelhor and Brown have suggested that you can utilize this theory to determine the level of traumatic sexualization in the client so that you can then create a treatment plan and interventions to start addressing the issues that are involved. So questions you may want to ask to assess the traumatic aspect would be, whether intercourse occurred, whether there was penetration or not, duration of the abuse, the degree to which the child participated, whether they were manipulated or they were willing participants. And then the stigmatization usually comes following the abuse, following having disclosed the abuse. So the age of the client makes a difference, the age that they were when they were abused, how long the abuse went on, the number of people who knew about it, and maybe knew about it beforehand and didn't do anything about it, or the number of people that knew about it following the abuse, and the way they responded to the child, and then the degree that others blame the child following the abuse or, didn't blame the child. And then betrayal, you want to ask questions regarding the relationship between the abuser and the child. Like I said earlier, the ones that are caregivers that are expected to provide protection for these kids is going to lead to a higher level of betrayal, as well as following the abuse, if they were believed or if anybody tried to protect them or help them to end the abuse in any way, or in any attempts to gain support from family members. And then the powerlessness component. So you can ask questions regarding how much force was used, to what degree they participated, again, the duration, and then the circumstances around the termination. What happened? How did it end? Who did you tell? Who knew? Who participated in protecting you following disclosure of the abuse? All right, it's also important that sexual education for children and teens be provided along with your treatment. So if you're working with children, sexual education is very important. As I was doing some research, some other countries do things a little bit differently than we do here in America, and some of these countries are starting sexual education as early as kindergarten, 5 years old, 6 years old. And from what I gathered from the research, those countries have lower levels of teen pregnancy and other various issues that we see here in America, which the research is suggesting that it's because the education is started at an earlier age. So that's something to consider. Ongoing support be provided for the victims of sexual abuse as they progress through these developmental stages, as tasks regarding sexuality have to be achieved and completed. And so for a child who is sexually abused, they may benefit from, support through their teenage years as they start dating, regarding their own body and their sexual image, any eating disorder sort of issues that may come up, as well as during trying to learn to form intimate relationships and healthy relationships. You can play a very pivotal role in a child's life, being a support there for those factors. All right, and then as well as sexual education for the kids, also education for the parents and caregivers regarding their child's development and process through that. The parents need education on how to respond as well. So working with the family as a unit and not just the individual seems pretty imperative. Okay, for those that are treating children, I came across this game-based cognitive behavioral therapy. This was some really cool stuff. I think you have to purchase it if you're going to use it. I'm not currently working with kids, but if I was, this would be something I would probably look into buying. It's just an, let me see, just a second, let me find that in my notes here. The game-based cognitive behavioral therapy is based on some CBT ideas for therapy. That's cognitive behavioral therapy, play therapy, and trauma-focused cognitive behavioral therapy. Play therapy has been used for a number of years with children because it's a way children already play. So when you play with kids, you get more in their world and on their level. Play therapy has been utilized by years for treating various psychological and behavior issues in children because it allows them to express themselves in their own developmentally appropriate way. It's more consistent with the child's natural manner of learning, engaging with others, and it also can kind of aid in communication. When a child may not know how to communicate well, you can communicate more effectively through play. And it's a good way to build rapport with these kids. And it increases their engagement as well. A child is more likely to engage with the therapist if they're playing a game than if the child is sitting on the couch and the therapist is sitting behind a desk and they're just trying to talk, and the child may not be as engaged. Plus, a lot of these kids, they have to come to therapy after school, so they've already been in school all day, and that's exhausting, and then trying to be engaged in therapy and can be difficult. So play therapy is a great route to go with children. So they've combined the CBT principles with play therapy and have come up with this game-based cognitive behavioral therapy. So the games, they actually have a book of these. Like I said, you could probably find those and purchase them somewhere. The games are developmentally appropriate, so you pick games that would fit your child's developmental level, and then each game has either a social emotional skill that you'll be working on, or it's very specific skill to coping with the abuse. And the games have fit into the 8 models of either rapport building, personal boundaries, so that's kind of like a coping skill to redevelop an understanding of boundaries, emotional regulation, linking the feelings to experiences, cognitive coping, education, relaxation training, and gradual exposure, as well as personal safety skills. So the sessions are 90 minutes. You're supposed to play the game with the child and spend time building rapport and working on the skills, and then you meet with the parent, you teach the parent the game, and then the child plays the game with the parent. And then ideally, the child and the parent are supposed to practice these skills and play these games outside of the session to continue developing those skills. All right, and then in treating adults, because a lot of times adults come in and they've had some sort of childhood sexual abuse that hasn't been addressed. So here's some various theories on treating adults. The prolonged exposure, which is it's a form of cognitive behavioral therapy that's designed to treat post-traumatic stress disorder by these clients are re-experiencing the traumatic event through remembering it and engaging with it rather than avoiding it, avoiding reminders of the trauma, instead experiencing those triggers and then coping effectively with them. My only concern with that one is that sometimes clients can kind of re-traumatize when they discuss the events openly like that. It can be very distressing. The session can be hard for a client or bring up a lot of emotions that could lead to that client not wanting to come back because therapy is very uncomfortable. However, the research says that's a pretty beneficial way of addressing it. Cognitive processing theory, which is really just, again, processing it, reducing the psychological stress, addressing the PTSD symptoms and the trauma from it, as well as any depression or anxiety that might be related. Positive psychology. Positive psychology deals with developing the strengths and focusing on the positive emotions to be generalized to positive relationship behaviors. So